Oh, thank you very much. This is a course that I've been lucky to be in at ASCRS as well, so it's nice to give it here in India. So I'm going to show a case of a very crowded anterior chamber with a brunescent lens. And we still get these in the U.S., even though it's probably much more common in Asia, particularly in China, but I think in India as well. I have no financial interest in any of the devices that I'm going to show. So, this is the history of the patient. He had angle closure in the left eye, is counting fingers, and what I'm doing is I'm showing you the right eye because with his lens I can at least use the slit lamp to show how there's almost no anterior chamber. How many people have seen these cases? You look at the slit lamp and the iris is right up against the cornea, and you're going, what am I going to do? And often you think of an extra cap, but the concern is, what about suprachoroidal hemorrhage? So this is the eye that is in question. And because of his angle closure, it's assumed that he's had damage, and his vision is counting fingers. And everyone has looked at this up until now and said, you don't really need to bother having surgery. It's really too risky. Plus, you're never going to see well with that eye. So let's outline some of the challenges in this case here. So the first thing I do is I put a little viscoelastic in, and immediately I touch the eye, and it's rock hard. It is so hard, I have no way to get the instruments in. I put a little viscoelastic in, it's still rock hard, and so what I'm going to do is decompress the vitreous with a pars plana vitreous tap. Now I'm going 3 millimeters back. You don't want to do this if it's a really nanophthalmic eye because you have no idea where the pars plana or pars plicata is. But this eye is about 19 millimeters axial length, so I'm going perpendicular to the sclera, and I have to think I don't want to hit the lens. So I'm going to aim toward the optic nerve, and then I go in with the vitrector with no infusion. And this way I can gently remove a little bit of vitreous, touch the globe, and when the eye starts to soften, I now know that I've decompressed it enough that I can put in enough dispersive to deepen the chamber. Now, I'm going to break the synechii, but with such a shallow chamber, beware, the entire stroma of the iris is adherent to the anterior lens capsule. The whole stroma is stuck on there, so I'm actually going to sweep under there with the cyclodialysis spatula, and look at how you can see the spatula right through the iris stroma inferiorly. It's that thin. So we need, therefore, to be very careful when we open up this pupil that we don't shred it or mince it so that we have all these little strands shooting around. So the question is, how do we address the pupil? So I do like either iris retractors or Boris's hook, but when I have a very delicate, thin iris, I will go to the Malyugin ring. One of the reasons is that not only is it gentle on the iris, but if I need to get a little bit more exposure peripherally, I don't have to just stretch it further like I did with iris retractors. I can move the ring around like a picture frame and expose different areas without further expanding the pupil diameter. Here comes the capsule dye, another device, very important here with this rock-hard nucleus because I just don't have any way to see, and so this is going to highlight the visibility for me, both for the rhexis, but also when I'm bringing in the phaco tip, because I need to avoid hitting the edge with the phaco tip. So critical, isn't it, to have the capsular dye? All right, now once we've done that, now we have to think about the nucleus, and I'm having a little trouble here rotating it. And this is usually a sign of weak zonules, which often accompanies these cases. So I'm going to say, well, don't force it. If you force it too much, you can tear everything. So what would you do next? We've got a brunescent lens, weak zonules, and I'm having trouble rotating it. All right. Well, I think you can start. At least I'm going to start my phaco. I need to have a trench or a pit. I like to do a half of a trench, try to rotate the nucleus, and then go right into vertical chop. And so I'm going to do at least that first trench, and then I'm going to rehydrodissect and maybe use 2 hands to try to rotate the lens, so that I have one to sort of fixate against the angular rotation motion. But look again, a lot of trouble rotating it. So this is time to not force it and put in capsule retractors. And they fit actually nicely over the ring. These are from MST Epsilon, but they support the peripheral capsular bag, and they give me artificial zonular support. They're like artificial zonules, so they fixate the capsule, letting me turn the lens within it. And watch how now I finally can turn the lens inside the capsular bag because I've anchored it, whereas before there was no zonules to anchor it. So now I've rotated at 180. I'm going to impale with burst mode and use the sharp vertical Chang chopper. It's like a Sinskey hook, but really sharp. And as I impale downward and I separate, I want to see that fracture go all the way through the posterior plate. And having done that half trench is really helpful in that regard to help me. So now I'm going to rotate, keep pulling these pieces out, keep re-adding dispersive OVD along the way. Now remember, we saw signs of weak zonules. So first of all, I continually refill the anterior chamber, recoat the endothelium with a dispersive viscoelastic, but I have to be careful now because the posterior capsule is not on stretch and I want to delay putting in the CTR. So I'm going to put in viscoelastic into the capsular bag. This deepens the posterior capsule on the capsular bag depth, but it mainly pushes the bag away from the phaco tip because remember, you don't have the normal stretch. It's not as taut as it normally would be if you had normal zonules. So now I have to be very careful, but you see that I only have this last little piece, but the capsule's coming up toward me, so I go back in, I blow the posterior capsule back, you use a dispersive so you will resist aspiration, and then I can pull out a few of the pieces here and the capsule is not flying up. Now we can put in the capsular tension ring. I'm going to put in a cohesive viscoelastic at this point and inject my CTR at this point. Let's see. So do we need a CTR here? Well, sure, we had weak zonules. As this goes in, be careful. It is possible to pass this through the double-stranded loop of the capsule retractor. So I have to be careful not to do that. It goes inside. These you can pull out just like iris retractors, or you can take off the knob and pull them out through the incision if you needed to. But essentially, you just back them out. And then we can put in our CTR, then our IOL. Now, because of the weak zonules, you don't want to leave the rexus too small. I'm a little obsessive about this. I actually like to sometimes go back and enlarge the rexus further. And this was my point. You see, I want to see more peripherally. If this was iris retractors, I just have to stretch it even more. But with the Malyugin ring, like a picture frame, I can just move it. I can move it nasally. I can move it to the right so that I can move my pupil rather than make it even larger still, because you remember how delicate that iris was. Then we would track this. We pull out the viscoelastic, and you'll see at the end of the case after I put an atovicral in my sclerotomy that we did preserve a functional pupil and didn't lose that. And that's the way the pupil was to start. So this is actually 1 week post-op, and the cornea is already compact, and so that is a tribute to lots and lots of dispersive OVD. And the surprise in this case was this eye that many people had given up on because of the prior angle closure. It's actually 20/30 plus, did have optic neuropathy, but certainly worth doing his surgery. Thank you very much.